Hi, I'm Sushant and welcome to this online tutorial by Quest. Today we are going to learn about management of acute kidney injury, and this is going to be an audio tutorial where we would complement whatever we have learned in our classrooms. So acute kidney injury is really not a diagnosis, it is a syndrome. It's an end point of multiple conditions where the patient would have a sudden renal insult. This would manifest in two of these ways. First, patients would have a decrease in the urine output. Now, such patients could present to us with either oliguria, that is a urine output of less than 400 ml per day, or the patient could come to us with anuria, which means there is less than 100 ml or perhaps sometimes no urine coming out throughout the day. That would be one way of diagnosing acute kidney injury. But the other way is because the kidney is not functioning, there would be an increase in the nitrogenous waste products. Patient would have an increase in serum creatinine and the urea levels. So I can diagnose acute kidney injury based on these two parameters. Either the patient has oliguria or anuria or the patient has rising serum creatinine. Now there can be a variety of reasons why the patient could present to us with acute kidney injury. Most of the patients would come to us because of a pre-renal insult. That means for some reason there has been a decrease in the blood supply to the kidney. This could be a patient who is hypovolemic, let's say because of diarrhea. That's quite common in India. You could have a patient coming with cholera and landing up with acute kidney injury. Or it could be a patient who has a decreased effective cardiac output. So let's say a patient with heart failure or a patient who has vasodilation like liver cirrhosis. All of these conditions, the renal perfusion has been hampered and that leads to a pre-renal acute kidney injury. But a big cause in India and across the world is sepsis. These are patients who have two problems. One, they have hypovolemia, but second, sepsis would have a direct injury to the kidney leading to intrinsic renal injury. So apart from pre-renal, I can also have now intrinsic renal injury as a cause of acute kidney injury. And the third, not so common but important, are the surgical conditions like obstruction to the urinary bladder or the urinary tract. This could typically happen because of a patient having prostatomegaly, and this would be characterized as post-renal AKI. We are going to now focus on management primarily of the pre-renal and the intrinsic renal AKI. So management of acute kidney injury would depend on identifying the cause. Well, sometimes I know the cause, sometimes I have a potential cause in mind. Now, if I don't correct the cause, there is no way that the kidney is going to improve. So for example, if I have a patient of complicated malaria with AKI, I need to treat malaria. Or let's say that the patient is on a drug, which is either the cause of AKI or is likely to contribute to an ongoing AKI. In all of such conditions, I need to correct the potential causes. But once I've done that, simultaneously, I need to start managing the other complications arising out of AKI. If the kidney is not functioning, what all is going to be deranged, I need to look at that critically and correct it as far as possible. So let's start doing just about that. First thing I need to correct is the hemodynamic status. Remember, most of the patients came to us with a pre-renal AKI. That means they had perhaps a hypoperfusion of the kidney, very likely because they were hypovolemic or sometimes maybe they were in shock. I need to correct this fluid status. Now, it might sound simple, but very often that's going to be a tricky parameter. Tricky for two reasons. One, how do I assess the patient's present volume status? I can do that clinically, but remember, this is a patient in the ICU and my judgments clinically might not be very appropriate. I need more objective parameters. So here, a central venous line or a central catheter can help me to guide what is the fluid status of the patient. But remember, the patient could also be on a mechanical ventilator. These are sick patients. So that might also change the way that I assess my JVP. The second question for me is, how do I replenish this volume status? What kind of fluid should I give? Of course, by the time it's renal injury, we cannot rely on oral resuscitation. We need to give intravenous fluids. And here, an everlasting question, which has been bothering us in science for like ages now, is what kind of fluid should I use? There have been ages and ages of work on this, but the controversy between a colloid versus a crystalloid fluid is still not salt. Colloids are fluids like albumin or HES, that is hydroxyethyl starches. But truly speaking, even if there is some evidence to say that they do perform well, we have two important questions, especially in a country like India. First is availability. Getting hands on albumin or HES is going to be really tough. And second is cost. At a high cost, are we really justified with the benefit that they give? We just do not have enough evidence to say that colloids are the best choice. There is evidence to say that they are probably better than crystalloids, but not enough to say that I'm going to give that to all my patients. So what majority of our patients would get in India are the crystalloids, and here the fluid of choice is normal saline. Normal saline, which is an isotonic fluid that is 0.9% saline, is very often given depending on the patient's fluid status. Now, what should be the dose of the saline? That would vary from patient to patient. So I'm going to assess the patient's clinical parameters, that is his heart rate, his blood pressure, his JVP, and decide the dose of normal saline. Typically, if the patient is in shock or if the patient is significantly hypovolemic, I would start with something like 1 pint of NS over the first hour. And gradually, I might reduce the dose to something like 1 pint or 500 ml over 3 to 5 hours. But remember, this is now more like an art than an actual science. I do not have very objective parameters here. So monitoring the patient on a very regular basis during these first few hours is very crucial. There is another problem to saline, that when I'm using saline, remember it is NaCl, and the Cl part, the chloride part, is slightly higher than what my usual extracellular space would have. So there is a risk that if I give too much of normal saline, my patient would have hyperchloremia, and this hyperchloremia would very often translate towards metabolic acidosis. That condition is known as hyperchloremic or non-anion gap metabolic acidosis. Another concern for us while I'm giving normal saline is to look out for the blood pressure as well. Remember, the patient could be in shock. Primary treatment of shock, if it is a hypovolemic shock or a septic shock, is fluid resuscitation. But if I've given adequate fluids and the blood pressure does not pick up, typically in the first hour, then I might be justified in using vasopressors. I wouldn't go into the details of which vasopressors and how do we compare them, but I could just rest the case saying today noradrenaline or norepinephrine is the vasopressor of choice. My second choice is dopamine. Using these two vasopressors, I'll try to get a systolic blood pressure above 90 mm of mercury, and according to the guidelines, I'll try to achieve a mean arterial pressure above 65 to 70 mm of mercury. There are trade-offs here as well. One trade-off, well, it's very tempting to use an inotrope and show that the blood pressure is high. But remember, if the volume is depleted and I give vasopressors, that might backfire. Without adequate volume in the blood vessels, using a vasopressors would cause further vasoconstriction and might actually worsen the acute kidney injury. So remember, do not give vasopressors till you are sure that your fluid resuscitation is in place. A second problem that we have noted is they can induce arrhythmias. Typically, there is a higher risk of arrhythmias like atrial fibrillation in patients who receive higher doses of inotropes. But overall, managing the fluid and managing the blood pressure will be my priority when I see these patients. Once I've achieved this, or while I'm achieving this, is there anything else I should be looking out for? Acute kidney injury means that the kidneys have suddenly shut off. That means the patient is not producing urine, which means some of these patients could be in fluid overload. Once the kidneys have got knocked off, once there is kidney injury, there is always a risk that because of oliguria, when I give fluids, the patient might not have the normal urine output immediately. There could be some time when the fluid that I have given might actually contribute to fluid overload. And such a fluid overload could mean pulmonary edema. Now let's put all of this together. A patient of AKI, that means, could be between a delicate balance of having too less of fluid and sometimes too much of fluid. Which of them is more dangerous? Well, the answer is both. If the patient is having low fluid, that is shock. If the patient has too much of fluid, that could be pulmonary edema. The best way to do this is do not overhydrate. But unfortunately, I do not have very good objective markers here. So if I find any evidence of fluid overload, that is the patient where I should use diuretics. And the diuretic of choice are the loop diuretics. Loop diuretics are going to block the sodium, potassium, chloride channels, which are basically there in the loop of Henle. And by stopping these channels, it is also assumed that they might decrease the metabolic demands of the kidney and therefore inhibit some of the damage that is going to happen to the ischemic kidney. But there is also another side to the story, that if I overuse diuretics, I might again aggravate a hypovolemic state. So I need to be using diuretics very judiciously. Now how about this? My patient was oliguric. That's why the patient came to me. Can I also think of it this way, that I'm going to use diuretics so that a patient who is oliguric starts producing urine? This might sound logical. Isn't that what I want? That a patient who is not producing urine output should produce an urine output. But no, that's not the reason we give diuretics. Remember, the purpose of diuretics in a patient of AKI is not that the patient should start producing urine, but the purpose is to take care of volume overload. If the patient does not have volume overload, there is no role to diuretics. Diuretics are a treatment of volume overload, not of AKI. I repeat, diuretics are the management of volume overload, not of AKI. If the patient does not have volume overload, please do not give diuretics. Most of these patients would be in a catabolic state, and also if they are in the ICU, their overall nutrition is going to be hampered. Remember, there are two ways to give nutrition to a patient in the ICU. I could give parenteral nutrition, which is through the IV axis, or I could give enteral nutrition. For all patients in the ICUs, in critical care, without a doubt now, it is enteral feeding which is the preferred mode of treatment. Another question here could be, what about glucose? These patients, when they are in the ICU, when their nutrition is being hampered, when they are on multiple drugs, there is a chance that the glucose level could fluctuate. Now, the optimum target of glucose is yet to be found. Believe it or not, we still have not reached a stage where we know what's the best level of glucose for a patient in the ICU. But with the patients having renal injury, we prefer that the blood glucose should be between 110 to 149 milligram per deciliter. This, however, is an ever-changing benchmark. So if you are going to appear for any competitive exam, I would strongly recommend that you go through this cutoff just before your exams. Another aspect I need to look out for is the electrolytes. Sodium very often would be corrected when I correct the fluid status. It is potassium that I really need to bother about. A regular monitoring of potassium that should be done every few hours, preferably every 12 hours, and correction of that potassium status is paramount. That brings me to those few patients who are going to have severe renal injury. These are patients of severe AKI who have not improved despite the previous conservative management. Now, these are not going to be a lot of patients, but when I come to ICUs, these are going to be a significant number. Of the entire range of acute kidney injury, these are around 5% of patients. But when I go to the ICUs, patients of AKI in the ICUs very often are going to have severe AKI. So these patients might require a renal replacement therapy. And you got it right, when I say renal replacement therapy, I mean dialysis. Now, the classical indications for renal replacement therapy are fluid overload. A fluid overload which I couldn't manage with diuretics. Electrolyte disturbances. A typical electrolyte disturbance is hyperkalemia, again something that I couldn't manage with medical therapy. Patients having metabolic acidosis, patients having uremic symptoms, and nowadays patients who have creatinine, which is typically more than 5 milligram per deciliter. What dialysis does is basically we are taking patient's blood, we are running across one side of a semi-permeable membrane, and on the other side we have a dialysis fluid. This dialysis fluid has an optimum concentration of solutes, and we allow for diffusion or sometimes convection, that is by force, a transfer of electrolytes and solutes between the blood and the dialysis fluid. By doing this, we are so to say reducing the nitrogenous waste products. We are also correcting the fluid status because we might be able to reduce the fluid volume that goes back to the patient's blood. This process is known as hemodialysis. Now there are some questions here as to which type of hemodialysis should I do. Whether I should do hemodialysis or there is another way known as peritoneal dialysis, should I follow that? Another question could be, should I be starting it early or should I wait for the patient to be symptomatic? Now to be very honest, these questions do not have exact answers yet. The answers could vary from institute to institute. But let's come to some of the basic things which are practiced across hospitals in India. 1. Should I do a hemodialysis, a process that I described just now, or should I do a peritoneal dialysis? Now in hemodialysis, the blood is taken out from a venous catheter. Very often this is a catheter in the jugular vein or the femoral vein. I take that blood out and then I dialyze it and send it back again through the venous catheter. While doing this, I have a risk that the patient could have hypovolemia and therefore worsening of shock. In such patients, where the patient is hemodynamically compromised, I am justified in doing peritoneal dialysis. In peritoneal dialysis, we insert a catheter within the peritoneal cavity and the fluid is allowed to stay in the peritoneal cavity and the peritoneum itself acts as a semi-permeable membrane. So from the blood vessels which are in the peritoneum, the blood would be cleared of its solutes. The advantage of peritoneal dialysis is the blood pressure wouldn't be abruptly brought down. The disadvantage, of course, is this is going to be a very slow procedure. One more advantage is this is going to be quite cheap procedure. So in resource constrained settings like India, it could be a promising therapy to look out for. The second question would be, when should I start dialysis? Now there is a lot of controversy around this point. The older thoughts were we should wait for patients to develop symptoms of volume overload, symptoms of uremia before we consider dialysis. But most of the nephrologists today would agree that we should consider early dialysis. That means we should not really wait for the patients to have significant symptoms. Now, this is a subjective parameter, but I would like to stress upon one part. It is not only the serum creatinine which decides dialysis. Serum creatinine is one of the markers, but we are looking at potassium, we are looking at pH, we are looking at the volume status. The nephrologist is really looking at the trends of all of this and taking a collective decision. And very often the question in mind is, this is a patient of renal injury, an acute renal injury. If I believe he is not going to improve, then maybe I should do a dialysis. If I think he is going to improve in some time, and that some time could be just next 2 or 3 days because I see the trends are improving, I might hold on and delay the dialysis. One of the worst markers here is the fluid status. So one of the most prompting need for dialysis is very often if the patient has volume overload. And then the last question, if I do a hemodialysis, which type of hemodialysis should I do? We can either do an intermittent hemodialysis or we can offer a continuous renal replacement therapy. An intermittent hemodialysis typically occurs in sessions of 4 hours and then it would be repeated after a few days, maybe twice or thrice in a week. But a continuous renal replacement therapy is a longer process. It will last for 24 hours or more. Now, most of the trials are now supporting CRRT, but the availability, the cost and the techniques might be cumbersome. So most patients in India still undergo intermittent hemodialysis. Now remember, the evidence in both of them is not so different to say that one is superior to another. So all the guidelines endorse that these two are complementary procedures. You could select what is available to you. When do I stop dialysis now? Should I continue it forever? A question that your patients are very often going to ask you. Remember, in acute kidney injury, as soon as the patient's urine output starts improving, we might be able to take him off dialysis. That time really depends on what was the primary cause and how well was the patient managed initially in his course. So let me summarize whatever we have understood. We have understood that patients of acute kidney injury are not really one disease. These are patients having multiple etiologies and I need to treat that etiology. I need to look at the fluid status critically. I need to use IV fluids as soon as possible, and of all the IV fluids, it's perhaps normal saline which is my best choice. I might also have to use blood pressure maintaining medicines, but I have to always keep a watch on adverse effects. While I'm giving IV fluids, throughout, I'm going to watch out for any evidence of fluid overload. This might not happen on first day, but the next few days, watch out for fluid overload. Because if that really happens, that puts your patient at risk of pulmonary edema. Management of fluid overload is by giving diuretics, and if that doesn't help, then I need to consider dialysis. The type of dialysis, the frequency of dialysis, and when to stop dialysis, these are really tricky questions. An experienced nephrologist would be able to help you at this time, but very often the end point is that the patient should improve out of this. I hope you found this tutorial helpful. I would really love to hear your feedback on this, and if there are any questions, feel free to reach out to me. Thank you and Jai Hind.